Today you will learn the skills and techniques to manage challenging behaviors that often show up when assisting residents with their daily mouth care. You may have asked yourself, how can I get this part of my work done without all the hassle? Perhaps today's session will shed some light on understanding the behaviors and learning some tried and successful techniques that, with practice, can help with reducing the stress of this daily routine for both you and your residents. Welcome to the session on managing care-responsive behaviors. Alberta Health Services has developed a mouth care training program to support healthcare providers in continuing care facilities to address the daily oral health care needs of residents. Recognizing that good oral health is an integral component of the residents' physical, social, and emotional health and well-being, the framework of the program has 4 parts. The first part, the mouth care planning with the RIE or MDS oral assessment tool in a mouth care decision tree format. The second part, oral care plan, a tool that's based on the RIE outcome scales that identifies residents' level of independence. Part 3, a daily mouth care plan that provides support and strategies for managing challenging behaviors. And Part 4, referral to dental professionals for treatment as required. Each member of the healthcare team has a role to play in supporting the residents with their oral health. Most residents in continuing care are in various stages of the disablement process, either from physical disablement, activities of daily living, or cognitive decline, or a combination of both. Understanding the disablement process can help us to provide more effective mouth care support to residents. According to the Alberta Health RIE data, long-term care facility residents fall into the last 3 levels of care, with the majority, over 80%, being in level 3 and 4. For a small number of residents, less than 3%, exhibit aggressive behaviors or extreme reactive behaviors in long-term care and SL4. For safety and time saving, 2 staff support is recommended. Each of these levels of care has unique common characteristics in communication and behavior, and needs around mouth care that help the care providers learn valuable techniques to assist them in delivering helpful strategies to provide mouth care with challenging behaviors. The mouth care planning process using the RIE tool is based on the disablement process model. The first level, level 1, indicates no loss, where the resident has no cognitive or activities of daily living loss. The resident is independent. They may require help with the setup process of their mouth care, for example, bringing out the toothbrush, toothpaste, dentures, or whatever mouth care products they may require, but the resident can perform their mouth care on their own. Stage 2, or level 2, early loss, are residents who are in the early stages of disablement. They're often showing signs of struggling with personal hygiene tasks. In this case, supervision may be required, where residents may need a little coaching to ensure that their mouth care is performed at least twice a day for 2 minutes. They may also require some help with the product setup. In middle loss, or level 3, residents now start to show more signs of disablement and more challenges with locomotion and toileting tasks. Assistance becomes more involved. As cognition declines, limited to extensive assistance may be required. Residents require more assistance with mouth care that may range from verbal guidance and cues to physically helping guide the toothbrush. There are different strategies for keeping the resident involved in their own personal care. In the late stage of loss, or level 4, in the disablement model, indicates residents are challenged with feeding themselves. At this stage, full assistance may be required, where residents are unable to perform any mouth care on their own. This level of mouth care has another set of management challenges and strategies to assist care providers. Reviewing question 5 on our pre and post test. Most residents in continuing care require assistance with their daily mouth care. The answer is true. As residents decline in their level of independence, the need for assistance grows. Data from the Alberta Provincial RIE tells us that over 80% of residents in long-term care require moderate to full assistance with their personal care, including their mouth care. Now we will look at behavior. What is behavior? You wouldn't ask a resident with COPD or lung disease to just breathe better, would you? Of course not. But we do often catch ourselves expecting someone with dementia to behave better, but this is a disease of the brain. Behavior for a person with dementia is their form of communication. If we just take the time to decode the message, it could save us time and frustration and make mouthcare experience more enjoyable for both the provider and the resident. In dementia, often we see the abilities of self-performance are lost in the opposite order that we gain them in infancy. Young school children often need to be reminded and coached to stay on task and keep up with their personal care. This is often the first loss experienced in early dementia. But like children, residents may often be resentful that they need those reminders. Young preschoolers often need a hands-on assistance with their personal care to ensure that they have completed the task adequately. This is the same type of loss that's experienced in middle loss, where we need to adjust our level of support to match their ability for self-care on any particular day. Like preschoolers, the needed help is not always wanted, and some days are better than others. Infants require full support in their personal care, as in the case of late-stage disablement. It is in this stage that behavior speaks the loudest, and this is the only form of communication that our residents have left. We have tools to share today to help decode what these messages may mean. Each stage of disablement has common clues that can help us understand where to start, understanding where they are in their world. In Level 1, Early Loss. Oftentimes in this level, the residents are still able to express their needs and can follow simple instructions. They may have some memory problems and may require assistance with complex tasks. They do not always ask for help, even if they need it. They often get upset and frustrated easily, and may have difficulties adjusting to new routines. This resident needs encouragement to maintain their independence in mouth care. We have to remember that brushing teeth is a complex task, and it requires many steps. Think of all the steps involved to prepare the toothbrush before you put it in your own mouth. Once you start brushing, you have to brush the outsides, the insides, the tops, then the tongue, while remembering not to swallow the toothpaste, but to spit it into the sink. Oftentimes, in this early stage of loss, some supervision is required, with coaching and/or cueing, to ensure that the end result adequately removes the debris from the teeth that can cause dental disease. You may need to remind the resident to brush morning and night for at least 2 minutes. They may also need to be reminded to take out and put in their dentures and how to store and keep them safely. In Level 3, or middle loss in the disablement process, communication may become more increasingly difficult. They may have difficulties understanding instructions and situations. They may have difficulties expressing their needs, and it may be easier to communicate using simple words and gestures. Oftentimes, a change of routine can be very confusing and upsetting in this stage. They may have difficulties with complex tasks, such as brushing their teeth, and may act out verbally or physically. They may require step-by-step instructions and/or hand-over-hand. During the Level 4 or late loss stage of the disablement process, oftentimes people become nonverbal and completely lose the ability to communicate. Communication is often limited to visual or sensory, sight, touch, and sound. The tone of voice and touch of the hand is very important to set the atmosphere. A gentle voice and touch to the face can go a long way to relax the resident. Oftentimes in this stage, the brain has an automatic function and response that is activated during mouth care. Oftentimes, a resident may bite down on the toothbrush, thinking that it is food or nourishment. They may fail to open their mouth when requested, and their body may become more stiff or rigid. It is important to realize that this is not a purposeful act, and that it is something that is just a function of their brain at this point. We will now look at some of the techniques for improving access to the mouth. The first technique is overcoming fear of touch. Oftentimes, fear can be a primary reaction in dementia when starting a new activity like mouth care. Taking the time to gently touch the patient and speak quietly to them to start the process can save us time. For some residents, massaging the jaw joint, or TMJ, or gently stroking the cheek before starting mouth care or during mouth care while speaking quietly to the resident about what you're about to do can help to relax the resident and may allow them to catch up to where you are. Oftentimes, the jaw muscles may become stiff from lack of use, and so a gentle massage can also loosen up those muscles, making it easier for the resident to open their mouth. The bridging technique, which is often used in other areas of continuing care. For the bridging technique, if you give the resident a toothbrush to hold onto, it helps to improve the sensory connection of the task that you are about to do to what they are able to focus on, the toothbrush in their hand. Oftentimes, the resident may bring the toothbrush up to their mouth at some point during mouth care. At this time, you may realize that that connection has been made. Giving the resident a toothbrush to hold onto can also be used for the distraction technique. Giving the resident something to hold onto, like a toothbrush, teddy bear, towel, or cloth, can also help to protect the healthcare provider from hitting or slapping or grabbing out. Another distraction technique we recommend is singing or putting music in the background, gentle touch, or just talking to the resident about the day. Oftentimes, just distracting them from the task at hand can give you enough time to get through the mouth care. The chaining technique is used to set up the mouth care for the resident. Make sure that the resident is a part of the mouth care process. Allow them to see you put the toothpaste on the toothbrush and get all of their mouth care aids set up. Then you can give that toothbrush to the resident and even bring their hand up to their mouth to get them started on the activity. This allows the resident to still be involved in their mouth care. The hand-over-hand technique is often seen in residents that have a loss of more physical abilities but not cognitive abilities. The hand-over-hand technique can work in two different ways. The first way, as you can see in the picture, is with the resident holding the toothbrush in their hand. And then, as a care provider, you can put your hand gently over theirs, helping them to reach all the aspects of their mouth. The second way the technique can work is with the care provider holding the toothbrush and the resident having their hand over yours, helping you to brush. This allows the resident to still be an active part of their mouth care, even if their abilities may not allow it. For this, we look at Clara's story. Clara was a young woman who had been living with muscular dystrophy for most of her life. She was wheelchair-bound and could not live on her own, but she still wanted to keep as much independence as possible. She had limited movement and muscle strength in her right arm and hand, and previously needed help for all of her mouth care. Clara was able to gain some independence by brushing parts of her mouth that she was able to reach comfortably. This was achieved by placing the mechanical toothbrush in her hand, with the toothbrush bristles facing upwards for the outside of her teeth, and then repositioning the brush to face down for the tongue side of the teeth. The hand-over-hand technique is used to help to stretch Clara's arm to get the back of her teeth. Once Clara was done this part, the assistance was provided by her care providers to complete mouth care. Clara was thrilled to have the opportunity to regain some independence, and the staff were rewarding in helping her. During the middle to late stages of disablement, caregivers are often encounter challenges in delivering care to residents. Oftentimes, a two-person technique may be required for other activities of daily living. If there are already two staff present for another activity of daily living, such as bathing or toileting or dressing, it is a time that you could try to use two people to do the resident's mouth care. It is important when having two people to keep the conversation simple and to make sure that the conversation includes the resident. We should watch our body language and make sure that we are not stiff or uncomfortable. It is also important that only one person provides instruction to the resident as to not confuse them, and to speak English or the client's native tongue if it is known. Oftentimes, in level 4 or late stages disablement, a client may not open their mouth when asked or may bite down on the toothbrush. It is important to remember that this is not on purpose. It is a reaction of the brain. So sometimes we need. If you have a resident who is not opening their mouth, first moisten their lips with a water-based lip moisturizer. Do not ask the resident to open their mouth repetitively or yell at them. Moisten the toothbrush with water and shake it out. Lightly hold the wet toothbrush on the resident's lips. Wait for the resident to part their lips as they taste the water. Gently wiggle the toothbrush to encourage the resident to part their lips and open their mouth. And then slide the toothbrush along the inside of their cheeks all the way to the back of their cheeks. Even if the resident never fully opens their mouth, if you're able to brush along the cheek side of all of their teeth, at least then you've done half the job. The two-toothbrush technique As discussed in later stages of loss, residents may bite down on the toothbrush, thinking that it is food. If you have a resident that often bites down on their brush, try to have a second toothbrush present. When the resident bites down, try to use the first brush as a bit of a prop to prop the mouth open, making sure never to pull the toothbrush out too hard, as you can break off teeth or the head of the toothbrush, and those could both become choking hazards. As you prop the mouth open with the first brush, get the second brush and start to brush where you can. If the resident then bites down on the second brush, move the first brush and start brushing on that side. This technique can be used to gain access to the lingual or tongue side of the teeth by using the toothbrush in between the teeth as a lever. Try not to ever press too hard. Willie's story is the story of a young man with a brain injury, and it is the inspiration for this technique. When Willie used to have his teeth brushed, his immediate response would be to bite and clamp down on a toothbrush. This was frustrating for any of the caregivers, and it usually took time to coax Willie to open, and therefore became impossible to brush the tongue side of his teeth. Utilizing Willie's strong nature and response to biting the toothbrush, the two-toothbrush technique was implemented. As Willie bit on the first brush, they used the brush to act as a mouth prop while brushing the teeth with the second brush. The facilitator was better able to access the tongue side with the first toothbrush handle that was used as lever. Once one side was done, the process would repeat itself on the other side. This technique works well with individuals that have impaired cognition, as it is an automatic reflex to close down or chew on items placed in the mouth. The brain perceives this object as food. Some individuals may bite or clamp down on the brush, while others may chew on the item. It is best to attempt removing the toothbrush clenched between the client's teeth when the muscles relax during the swallowing process. It is important to use toothbrushes of a higher quality so that the handles will sustain the pressure of biting. Low-cost toothbrushes are often made of low-density plastic that may break under excessive pressure. As you perform mouth care, observe the residents for changes in their behavior. Watch for changes in facial expressions, such as eyes and eyebrows. This can be the beginning of agitation that can lead to more aggressive behaviors if not addressed right away. My favorite picture is on the bottom, with the lady's eyes wide open. Clearly you've reached the point of her tongue where she's no longer comfortable. Holding or grabbing can also be a sign of communication. Maybe your technique of the toothbrush angles is off, or maybe you're pressing too hard. Pushing or pulling away of the caregiver's hands can be a communication of pain in that area, agitation, or a need to change the approach. You can try the hand-over-hand technique, allowing the resident to guide your toothbrush and giving them some more independence and control. Simple respect can be forgotten in a busy day, running from room to room, but it is important to recognize that as you enter this room, you are entering the resident's home. Knock on the door and introduce yourself as you come in, keeping in mind that every resident may not remember who you are, so make a habit of introducing yourself and telling them what you're there for. Don't rush at them with a toothbrush and expect them to open their mouth. Speak slowly and move slowly, explaining what you are doing and setting out the mouth care products so that they can watch the process. Make eye contact and even use gentle touch where the resident will allow it. Make small talk, talk to them about the day, the weather, or mention pictures if they have any hanging in their room. Explain to them that you are here for their morning mouth care and tell them that you will be bringing out their products and remind them the importance of keeping their mouth good and healthy. Ask permission by giving them a choice. If they have more than one toothbrush, ask them which color they'd like to use today or which toothpaste. Ask them how much toothpaste they would like and if they would like to start on the top or the bottom. Giving a little choice every day will make the resident feel involved in their mouth care. You don't have to say if they would like to have their teeth brushed today, but at least if you can give them a few options to help make it easier for you and them. And also give the resident time to respond. Nice and easy. This was taken from the Alzheimer's Society. Use the name the person prefers, Mr., Mrs., Miss, or their first name or a nickname, but find out what they like to be called. Identify yourself every time you enter the room, even if they don't respond. Make contact using gentle touch or reassuring comments. Speak slowly and clearly and use short, simple sentences and one-step directions. Explain each step before you do it. Use simple language and repeat the message in different ways if needed. Give positive feedback and encouragement throughout the procedure, and do not use elder speak or baby talk. Enter their world. Empathize with the person and validate their feelings. Join the person where they are in their reality, joining in on their journey. Respond creatively to help them find comfort in a situation. All in conversation should include the client, keeping an eye contact and positive body language. Communicate using environmental cues such as personal belongings and photos, and speak English or the client's native language if you know it. Ask permission, but do not argue or criticize. Beware of your tone of voice and be patient. And smile. A smile can go a long way, remembering that body language speaks louder than words. Use gestures and props to help communicate. Hold out items to ensure that they are visible to the client. Remember, you are the key. You want to make it a positive day for yourself and your residents. Success is in the approach. The goal is to make mouth care a time that both you and the resident can look forward to. It's time to focus on the person, but not the task at hand. Try to build relationships where you can. And routine. The same person, the same time, the same place when possible. Remove distractions, unless you're using the distraction technique, and try to turn down the radio or TV and turn the person away from it. Include setting up supplies as part of the routine. This can help the people make a cognitive connection between what you are doing and what they can see. Encourage residents to participate to their level of independence, even if it's just making the choice on which side to start. Martha's story is of a senior-aged woman living with middle-stage dementia and was a wanderer with limited verbal communication abilities. She often did not cooperate with morning mouth care, and the staff requested some suggestions on how to address this challenge. One day, when the staff was doing the mouth care training approach, they saw Martha wandering around her room at about 10 a.m. They brought the instructor in to do a mouth care demonstration. They were greeted by the wandering Martha on the way on their way with a toothbrush in her hand. The trainer quickly fell into step with Marcia and engaged her in a conversation about her toothbrush, asking her if she would like to have her teeth brushed now. Martha led the group back to her room, and the trainer assisted her with her brushing. The trick for success was to conduct brushing on Martha's schedule. She did not want to have her teeth brushed first thing in the morning. She preferred to wait until after coffee at about 10 o'clock. The golden rule of caregiving is to treat others as they would like to be treated. Taken from Supportive Pathways.